Hello, everybody. James here, and welcome back to the pre-hospital case study of Grander. Sorry I had to scale it back over the past several weeks. Since August, really, we've been really falling behind. There's been a lot of work to do. We're really backed up, so I can't really commit right now to doing a case every week, but I will try to do a case every 2 weeks, but guarantee you that I will post one case at the beginning of every month for the monthly pre-hospital case study. And if I'm able to do it every 2 weeks, I will. And hopefully, as things wear down throughout the winter and we get everything squared away, I'll be able to get back on to doing about a case a week. So, without any further ado, I don't want to keep you all day. We'll go ahead and start the case. So, this call is for a 79-year-old female who is very dizzy. When we arrive, she's standing up on her own, but kind of leaning with her arms around her husband. And she keeps saying she can't stand up, she can't pass out. She's afraid if she takes one step, she's going to lose it. So we sit her down in a kitchen chair and examine her. We find that she's ashen gray, very cool to the touch, profoundly diaphoretic. She's very tachycardic with a weak, irregular radial pulse. So we take her vital signs. Heart rate's about 130, palpating it manually. The blood pressure is 70 over 20, very faint, and can only be heard via auscultation. Respiratory rate's about 24. SAT's 92 on room air. Glucose 174. Wouldn't it have been nice if it was 30 and you were able to give glucose and correct all these things? But couldn't be so lucky. So the next logical step is there's two paramedics on the scene at the same time, two partner paramedics. One partner paramedic starts doing the interventions, doing IV, starting fluid, getting the oxygen on the patient, and I started doing the EKG. And so we put the patient on the floor lead. This is the first thing that shows up. So at 9:20 at night, we find this patient. We see, there are some abnormalities here, but as everybody that has been in pre-hospital or emergency medicine for any period of time knows, that the floor lead's unreliable. It will make ST elevation look baseline. It will make baseline look like there's huge ST elevation or depressions. So anybody who's done it long enough knows that you can put the floor lead on someone, look at the monitor, you think, man, that is a huge ST elevation. This person's having MI. You do a 12-lead EKG. You're all excited, and it's nothing. It's baseline. Everything's baseline. There's no ST elevation at all anywhere. So that's why you have to do 12-lead EKG, because the 4-lead part of the monitor is not calibrated for intervals. It doesn't measure height, negative T wave, depression, doesn't measure the interval lengths. So you have to do the 12-lead EKG because that is the part of the monitor that's calibrated. So, of course, you look at this EKG, and there are some concerning factors. You think, man, there's some ST depression there. Maybe there's some ST elevation here. Clearly, the patient's in AFib. And what's the rate? So you find, if you want to do the quick box method, you find two that are pretty much on the line, and this patient's almost exactly at 150 beats per minute at these two. Because, of course, the first big box is 300, the second big box is 150. So the patient's just about 150, sometimes a little bit faster, and sometimes a little bit slower. So the next logical step, obviously, is to do 12-lead EKG, which we did. So up at the top, on all the EKGs you're going to see on this case, this is the time of day. So 21:21 at night, we gave the first EKG. This time indicates the time since the first EKG. So this one is 0 because this is the first EKG. If the next EKG is 10 minutes, that means that EKG was performed 10 minutes from the original EKG. So we look at this EKG, you see it's clearly AFib, it's tachycardic, there's ST depressions all over, laterally, anterior laterally, all out in the precordial leads, ST depressions everywhere. There's some borderline ST elevation here, and there's kind of this funny looking T wave that goes up and then down, and maybe there's a little ST elevation out here, not really any up here, but you might have an inverted T wave here. So you're looking at these ST elevations, you're thinking, man, there's some ST elevation, there's ST depression, you think this is going to be a STEMI. How do you prove it? There's no ST elevation in a contiguous lead. it's 9:30 at night on a Friday, and you know no cardiologist is going to want to be woken up for a cath lab activation when you don't have the evidence you need. So for me, this EKG actually has the evidence you need. There's some hints in here that is screaming this patient's having a STEMI, and we're going to go over those in just a couple of minutes. So there are some actually clues that a medical detective could do to go through this and say, man, this is having a STEMI. And just to go through the case, just to kind of skip ahead real quick, we did activate the cath lab on this patient. The medical resident and our medical command physician at our facility decided, yeah, this is high risk enough, looks reasonable. This is probably a STEMI. Let's activate the cath lab. She did go to the cath lab based on this first EKG, got 4 stents placed in, was discharged to home without any major cardiac damage. So now that you know this person definitely had a STEMI, had emergent stents put in through an emergency cath, you know there's some clues in this EKG now that could help you say, man, this is a STEMI. And just for those of you who aren't buying that this is a STEMI based on this EKG, you look down here, the machine doesn't buy it either. It says, diffuse ischemia, abnormal EKG, but you're not getting that bing, 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 this is a huge STEMI, emergency, emergency, with all the alarms. So we're going to talk about some of the things on this EKG that really screams that this could be a STEMI. So first is the morphology of this ST depression. And what I always say is if you can turn the lead upside down and it looks like it's a correct right side up STEMI, that is a morphology that you really have to be paranoid about. So imagine if you just turn this lead upside down. That's a STEMI, right? You turn this lead upside down. Sorry about the bad drawing. So that's a STEMI, right? You turn this lead, it's upside down. Right? That's a STEMI. So if you have ST depression that you could flip and look at it in a different light, looks like a STEMI, then you're likely having STEMI-related ischemia. The other clue in this particular EKG is oftentimes when you have an inferior wall infarct, the first thing to go is a flip T wave and ST depression and AVL, followed by V1, and then you start getting the ST elevations out here in the inferior leads. So maybe that's why the elevation hasn't creeped up in the inferior leads, but you have this other evidence with these ominous looking reciprocal STEMI ST depressions in the lateral leads, which scream, I'm starting a STEMI. The other thing that you see is these weird biphasic up and then down T waves. And you do have this one single lead that has ST elevation. So all these are pointing us in the direction that this patient is having a STEMI. So let's talk about some of these morphologies real quick. ST elevation, should you worry about it or not? And here's the easiest way, and not everything is certain. Not everything in medicine says it's either one way or another way. It can't be both ways. So usually when you have this upward curve, like over here you have these upward curve, over here, upward curve, you think this patient is not having a STEMI because it's an upward curved ST segment. So what could cause these types of ST elevations could be early repull, it could be LVH, it could be a left bundle branch block, it could be pericarditis, many things. But this type of upward sloping that creates a smiley face, you think, yeah, this person's not probably, having a STEMI. So you think, man, if you have a smiley face, this person is happy because their arteries are clean and their blood is flowing. Okay, that's a happy artery. Now over here is not so nice, right? So if you have this horizontal straight line ST segment, you have frowny face, ST segment, right? Frowny face over here. You think this uh, concave or or tombstoning or frowny face kind of ST segment. You think, man, this person. See here, you got the straight, and then you have the frowny face. So you think this person is not happy. This guy's saying, man, my life is sad. I'm blocked. I'm not getting enough oxygen. And this guy is really sad. He's like, I'm doomed. There's no oxygen coming. So here you have the little straight face, and he's sad. And then you have this really sad guy because he's not getting enough oxygen. Look at that tombstoning. He knows he's not getting enough oxygen to survive. This guy's pretty sad. And the other thing about these STEMI ST elevations, sometimes you get no ST segment at all. So if you look like here, you have no ST segment. The R wave goes right into the T wave. That's called the RT or the check mark sign. And you can see that up here. This here looks exactly like a check mark. So if there's none of this, there's no ST segment, okay? If you look on the left side, these all have kind of a ST segment, okay? Over here, a little ST segment. If your ST elevation goes down, it goes check mark, and then it goes into the T wave. That's called an RT sign. Very typical of STEMIs, not typical of STEMI mimics. So when you have that checkmark sign, you think, man, that's pretty ominous. So we'll move on to the ST depressions. Now, like we were talking about, when you have that one that you can flip upside up and think, man, that's a STEMI. So you look over here. This guy definitely could be a STEMI, right? If you turn him upside down, oops, I'm already doing it wrong. You turn this guy upside down, he's got a negative, and then he goes up, and it's like, bam, I'm so sad. Look at me, I don't have any oxygen, I'm very sad. So if you can flip that ST depression upside down, it looks like it would be a STEMI. If it was upside down or inverted, then you should be highly suspicious that this patient is having a STEMI somewhere, or at the very least that this ST depression is cardiac. So oftentimes those patients either have this kind of downsloping ST depression with an inverted T wave, little bit of downsloping like here, or pretty big downsloping here, or they'll have this horizontal, okay, this horizontal kind. The upsloping kind, I'm not saying that that patient is not having a STEMI or is not having cardiac related ischemia, but these ones you have a better bet that this isn't rate related, this isn't respiratory. This one usually is a patient that is having pretty serious cardiac ischemia. At least you could have a high index of suspicion of that. And remember, nothing's certain. So someone over here with this upsloping ST depression could be having a STEMI, whereas someone over here with this downsloping, ominous looking ST depression might not be having a STEMI. So it just increases your index of suspicion when you have this downsloping inverted T or this horizontal ST depression. So then we'll talk about those biphasic T waves. Whenever you have a T wave that goes up and then down, like this one. So you have the baseline goes across, and it's almost like a mirror image of itself. Goes up and then it's down. So that's called a biphasic T wave that is terminally negative, which means the end of it is below the baseline. Here, this one has a little ST elevation with it. It's up and then it's down. Here, you go across the baseline, up and then it's down. So these things, biphasic T waves, are considered an ischemic finding. You think, man, this person might be having a blockage in the leads that are affected. Now, if you have them in the mid-precordial leads like V2 or V3, that is a pretty specific indicator that you're having a critical LAD blockage. That is almost a STEMI equivalent. But when you find them in the other leads, there's not a lot of documentation that backs up that they're as specific or as sensitive that if you would find these findings in 2, 3, and AVF, that patient would be having an inferior inferior MI. But there is the suspicion that those might be one of the first findings that you'll find in the inferior leads when there is a blockage inferior. Over here on the right side, just quickly, this is a biphasic T that is the other way around, where it goes negative, then positive. That's a terminally positive biphasic T wave. And those waves, sometimes called reverse Wellens waves, because these waves over here, when found in V2 and V3, that's called Wellens syndrome, and these are called Wellens waves. If these are often called reverse Wellens because they go down and then up. And usually this is found in like hypokalemia. Patients will have a biphasic T wave that goes down and then up, not usually associated with ischemic coronary disease. So if we take a quick look at this initial 12 lead, what we see is all kinds of things. We have this ominous ST depression, right? We have this one that if you turn it upside down, that's a STEMI. You turn it upside down, that's a STEMI. You turn it upside down, not a big one, but that's a STEMI, right? These ones out here don't look as bad, but you have to be careful when you have ST depression or ST elevation anywhere, because remember, nothing's certain. You have these biphasic T waves out here. You have these biphasic T waves out here. So these might be an ischemic finding, if nothing else. And here you have some ST elevation. Looks like a STEMI. I mean, this lead here in lead 3, this first EKG is screaming. Lead 3, I'm having a STEMI, but you just don't have any other evidence to back it up. But when you put it all together, you say, look at these ST depressions, look at the morphologies, look at these biphasic T waves over here in the inferior leads. This person, I'm confident is having a STEMI. You convince the medical command doctor, you activate the cath lab, and you can literally save that patient's life. Now, for those of you non-believers in serial EKGs, I'm about to blow your theories about how they don't matter out of the water. So this is the second 12 lead at 21:29, which was 8 minutes and 35 seconds after the initial 12 lead. And you can clearly see that the ST elevations inferiorly, lead 2, ST elevations, no more biphasic T's. Lead 3, huge ST elevation, no more biphasic T's. AVF, no biphasic T, clear ST elevation. You now have enough to call out. This is an inferior MI, clear ST depressions laterally. But interestingly enough, out here, you still have this ST depression in V2. But V3 is kind of when baseline. There's not really any depression there anymore. And out here, V4, 5, and 6, there's no ST depression. V1, no ST depression. This is all pretty baseline. So just because there's all this artifact out here, and I didn't like it. I'm a guy that likes a nice, neat EKG. So I decided I'm going to repeat the EKG. So I hit, as soon as this one prints out, I hit the button again. Just over 1 minute from 12 lead 2, I do 12 lead 3. And you can see the active changes. Inferior leads are worse. This ST depression in AVL is worse. V5 is actually elevated. V1 is positive, just a little hint above the baseline. And for those of you non-believers, I'll put this side by side. Literally, you can see right here in the times. So this is not being fudged. I'm not exaggerating anyone. At 21:29, we do lead 12 lead 2. 21:30, we do 12 lead 3. And you can see, even if you're a non-believer, you put the baseline in there. V1, nothing. V3, that's pretty baseline. You look down here. V1, these are all definitely positive above the baseline. You look at V3, man, is that above the baseline. That is definitely going to be some ST elevation. Now, like we had talked about before, nothing is ever certain. So you look in V3, and in this case, for this brief period of time, you have this upward curved ST elevation, and you think, that could be early repull. That could be, whatever you want to call it. That might not be STEMI ST elevation. So you can believe what you want to believe, but there's enough evidence here. Clearly this patient's having a STEMI. There's no question about it. So you don't even really have to worry about V3. So we decided to do the last 12 lead as we pull into the hospital, which is 17 minutes and 30 seconds after we do that initial questionable 12 lead. Look at these interior leads. Inferior wall, huge tombstoning. Look at this checkmark sign, okay? You have that. You have the checkmark sign. You have this huge, looks like a STEMI upside down. Over here, STEMI upside down. There's no question, inferior wall MI. But look over here, V3, V2. Uh, V2, the ST depression is not as bad. V1, clearly elevated. V3, huge tombstone RT style elevation. And even out here in the far precordial leads, we have some ST elevation. So we'll put some baselines in there for you non-believers, and we will show you clear ST elevation, even if you want to say that's not diagnostic because it's only in V1 and it's not really that high and the baseline's a little wandery. Clearly, if you stretch that across, there's ST elevation there. Go down here, huge tombstone RT elevation, huge. In just a matter of 17 minutes, V3, V4, V5, V6 went from being depressed to having elevation, with V3 being tombstone elevation. Here, even if you don't want to believe it completely, there's ST elevation there, and it's just going to keep getting worse. This patient is going down the wrong path. So just to compare the dramatic changes in just how you would look at it at a 12 lead. So based by the leads go straight across and the time of EKGs go up and down in the columns. So 0 is the first 12 lead, 8 minutes, the second 12 lead, 9 minutes, the third 12 lead, 17 minutes is the final 12 lead as we're backing into Allegheny General Hospital. You can see it goes from this questionable biphasic T to this huge tombstone STEMI in just a matter of 17 minutes. You can see that this goes from ST depression to this tombstone STEMI out here in just 17 minutes. ST depression to ST elevation, just 17 minutes out here in the far precordial leads. So anyone who thinks that, man, we just put the 4 lead on, this person's symptoms, low blood pressure, sweating, feeling like she's going to pass out, that's all coming from her being a new onset rapid AFib, and you just want to treat her for that. You don't do an EKG, which I would never condone. Literally, people think, well, the hospital will do it. So there's a couple problems. One, the patient might not make it to the hospital. If this MI is rapidly evolving the way that this one did, that patient might not make it to the hospital without supportive care. Secondly, you can never count on someone else to do your job. You can think, well, I don't have to do an EKG because someone in the hospital will do it. Healthcare, as any long-term practitioner knows, is really fractured. It's almost like everybody has their own specific task, and everybody, all the doctors are just consulting on their one section, and the emergency room doctor is just looking at the one thing that is the patient's complaining of, and the nurse might be doing one thing, and another nurse is doing another thing, and the tech is doing another thing. And there is the possibility that the EKG could be missed for at least a short period of time. So we always advocate when we're teaching our paramedic students that if there's something you can do in the ambulance for a patient to make them feel better, or to make sure they're not going to die, or to make sure they're safe, or to evaluate them in any way, if there's something you can do in the ambulance for that person, you should do it. Just do it and get it over with instead of really just pawning your chores and your duties off on somebody else, because you can never be guaranteed that that person will do it, and then it really is your responsibility if something negative happens to that patient. And we should never be doing anything negative to anybody. So, to boil this case down, beware of any ST elevation, any ST depression, any ST inversion all the time. Study them carefully. Look at the morphologies of the ST elevations and depressions. Watch out for those T waves. What are they doing? Are they up? Are they down? Are they depressed, down sloping with an inverted T, or is the T upright with ST depression? And watch out for those biphasic Ts. Remember, there is no guarantee that anything is as it seems. So even that ST elevation that looks like it's early repolarization, you can't just blow it off if that patient's having cardiac symptoms. And conversely, you can't just say this is definitely a STEMI because there's ST elevation, because there's other things that go down that path. So you got to think about other things like, are there reciprocal changes? What does that elevation look like? What's the morphology of that T wave? And finally, do EKGs and do them often. Cheapest test there is, just costs 10 stickers. You already bought the monitor. And in just 17 minutes, this patient's EKG was transformed from being a questionable, borderline, I don't know, let's just wait until we get to the hospital. And if you didn't repeat that EKG, or if you didn't even keep that patient on the monitor, by the time you got to the hospital, you would have looked really foolish if you brought in a multi-vessel emergency STEMI without doing your duties. So give everybody the benefit of the doubt. Do your EKG, do them often, repeat them over time. At least, you know, if you have cardiac symptoms, maybe you should do one as soon as you get to the patient's side, halfway to the hospital, and when you're backing in. I think that is a fair way to do serial EKGs. And if there's no changes, then so be it. And you won't see changes very often that happen right in front of you. But when you do, when that one case happens, it's worth the 50 other cases that you did serial EKGs on and didn't see anything, because you can make the difference in that patient's care. And finally, I thank everybody for stopping by, listening to my EKG case of the month, pre-hospital case study of the month, excuse me. And I'm always open to taking your interesting cases or your good EKGs. You should send them to ekgs4james@gmail.com. Uh, Good EKGs could be featured on the pre-hospital case study of the month, or it could go into the textbook I'm writing on EKG interpretation. You'll get the credit for it. And if you have an interesting case that doesn't involve EKGs, or if it does, even better, send it to me and you could be featured in the pre-hospital case study of the month. So thank you very much, and I hope to talk to you guys next month in December.